Okay, welcome everybody to the session Assessing and Intervening on Behaviors and Psychological Factor in the New Area of Combined Therapy. Please turn off your cell phone or keep it on silent. Remember that recording during the presentation is not allowed, and you may ask your question through the Congress app. Let me introduce to Dr. David Creel. He's a clinical psychologist, exercise physiologist, and registered dietitian. He works in the Department of Endocrinology at the Cleveland Clinic, where he leads the Division of Physical Activity in the Enterprise Obesity Center. In his clinical work, he enjoys integrating his patients' value, and he works alongside them to manage weight and improve life quality. He will present the lecture titled Importance of Dietary and on Eating Behaviors in a New Area of Combined Therapies.
Thanks, everyone. Thanks for being here so early. It's been a great conference so far. And now, Dr. Herrera did not want to introduce herself, so I want to just share a little bit about her because she's been instrumental in helping plan this session, and she's really been helpful with introducing us to Chile. So how many Chileans do we have in here? Okay, not too many. But this has been a great venue, and thank you so much for all of your help and teaching me all about new words and Spanish and that sort of thing. So Dr. Andrea Herrera Santelices is a kinesiologist. She has her PhD in health sciences. She's a full professor of the School of Medicine at the Universidad Católica de Male. That's my best Spanish. She's a researcher at the Physical Medicine and Rehabilitation Department of Curicó Hospital. In her clinical practice, she supports her patients in making lifestyle changes to incorporate physical activity and improve their quality of life. So we're going to have 4 presentations today, and there's going to be a lot of time for Q&A and panel discussion. So please use your app to ask questions. Or if you want to ask one in person, we'll have a roaming mic. So feel free to do that. Even if you're not speaking, it doesn't mean that you don't have something important to say, so we want this to be a discussion. And I know my guess is the room will start to fill up a little bit more as everyone has their coffee, but feel free to participate. All right, so I'm going to talk a little bit about, you want me to do I can do psychosocial first, that's fine. So I've got 2 presentations today, so I'll do the psychosocial first, and I can do the dietary things later. All right, nothing to disclose. So when we think about psychosocial variables, I feel like I've said this a lot at the conference, but there are many things that we can consider, right? So common things like depression and anxiety, we have the eating behaviors, restraint, binge eating, but there are many, many things that we could consider. And we look at references in health economic models, and many, many things are referenced. So, psychosocial variables are complex, people are complex, and we need to consider that in our treatment. Looking at a recent systematic review and meta-analysis for GLP-1s and mental health, people are asking about this, and what we're seeing is there's no associated increased risk with psychiatric adverse events, or worsening of depression. Now, this is overall, right? When we look at reviews and meta-analyses and that sort of thing, that does not mean that you won't have a patient that might have a negative reaction. So we see this sometimes. People have expectations of what's going to happen after they take the GLP-1. It's not met, or they have side effects, they have pain, and that can adversely affect their mental health, obviously. Overall, I don't probably need to tell you guys this, but we are seeing improvements in quality of life, improvements in restrained eating, and improvements in emotional eating. How many of you have had patients that come in and they say they're an emotional eater before they start a GLP-1, and then they come back after they start and say the emotional eating went away? Has anyone? Yes, right? It's like, okay, it makes you ask, well, was it emotional eating to begin with? Was it appetitive drive? Or was it some combination of the two? My guess is in most cases it's a combination of the two. Yes, there's some emotional eating, but there's some appetitive drive. And a lot of those people are still doing well coping with their emotions. Not everyone, but a lot of people are still doing well. And we have that discussion about how they're managing their stress despite not using food in that way. Looking at an umbrella review for mental health outcomes in MBS. So we know that MBS can improve anxiety and depression, especially in the first 2 years after surgery. It improves eating behaviors typically, not in everyone, but overall, that's the general consensus. I will say that when we look at studies that are further out, beyond 2 years, we start to see some return to baseline for anxiety and depression. So that's something to be aware of, that we're not sure of all the mechanisms, but certainly when you feel better, you're able to move better, that can impact your mood. But over time, people might still have depression and anxiety as we get further out from surgery. Some concerns related to metabolic and bariatric surgery are suicide and self-harm. So we see an increase. If we look at the umbrella review, the review of reviews, we see that there's an increased risk of suicide. Again, we have to look at the incidence of suicide is still very, very low, but we do see this increase. So it's like, well, what's happening? Depression and anxiety tend to improve, but suicide goes up. We don't fully understand why. Is it about expectations, change in relationships for some people? What's going on? We don't fully know. Is it a change in the microbiome that could affect things? Again, just not really sure. And it's been well documented that we have an increase in alcohol use disorder. Probably most of this is related to how alcohol is absorbed. One drink is like having 3 drinks after a Roux-en-Y. So we need to always be aware of that. And as we're following people up after surgery, asking those questions. We published a paper several years ago looking at psychosocial and behavioral correlates of weight loss 12 to 15 years after surgery. It's a smaller sample, about 125 people. But we saw there was a statistically significant correlation between life satisfaction, conscientiousness, positive affect, food addiction symptoms, and long-term weight loss. So these psychosocial variables are important. Again, these correlations are not extremely high. When we added physical activity to our regression modeling, we found that we could account for about 23% of the variance with positive affect, food addiction symptoms, and physical activity. So the message I kind of hear from this when I see these data and also from clinical work is that psychosocial variables are often overlapping and they interact, right? I mean, it's rare that I see someone who has food addiction symptoms. We can debate what that term food addiction, but by the food addiction scales that we use, that also is not struggling with some other things, right, emotionally. When someone struggles with depression, they often struggle with anxiety. So they're overlapping. Conscientiousness is something I showed on the previous slide that we see in a lot of studies. So people who are more conscientious respond better to healthcare advice a lot of times. They tend to be more organized. They're able to follow things than people who maybe their executive functioning is not as good or their attention is diverted. It's important to consider physical activity in the context of life satisfaction, positive affect, and impact on executive functioning. So again, physical activity can affect these things. Wendy King published a paper several years ago from the labs data, the longitudinal assessment of bariatric surgery. She showed that physical activity was related to depression after surgery, I think up to 7 years after surgery. So realizing that physical activity is not just about weight management, but some of these other life satisfaction, psychosocial variables, it may impact those as well. And I'm sure our other speakers are going to talk more about that. We don't have a lot of data on GLP-1s and kind of how behavioral treatments are related. This is an older study with not using tirzepatide or semaglutide, but using some of the other medications that don't yield as much weight loss but are used for diabetes. And this was retrospective, but they looked at standard care, they looked at elementary nutrition education, which they have 5 groups, or CBT 12-group sessions. And they looked back and they said, well, how did people do? So you can see that the standard care did not do as well as those who got nutrition education and CBT, cognitive behavioral therapy. And it looks like the CBT, at least at some points, was more effective than just the nutrition education. Now, this is retrospective. The people who had CBT had more sessions than those with nutrition, so we have to keep that in mind. Maybe it's the amount of contact that matters a little bit more. But it's very important that we don't just say the medication will take care of everything, or the surgery will take care of everything. I think we do, I don't know what you guys think, but I think we do a pretty good job now with metabolic and bariatric surgery. We have systems in place. We do evaluations. We talk about risk-benefit, what the surgery will do and won't do. I don't think most places have those systems in place for medications. I don't know. How many of you would agree with that statement? At least some of you. Okay, very good. All right, I showed this slide in another form on Tuesday, but I was talking about cognitive behavior therapy. Some people, what is that? Well, cognitions, our behaviors, how are these all related? So I think as practitioners, we need to consider how these are all interacting. We might be able to change our situations at times, but a lot of times we're not going to be able to. So how do our thoughts, emotions, and behaviors interact? Not just focusing on behaviors, but what are the thoughts behind these behaviors? What are the thoughts that are leading to emotional distress? And how do we kind of work in this system? 2 main types of coping. I show this slide to my patients many times, or in groups. We have emotion-focused coping, and we have problem-focused coping. Problem-focused coping is dealing with the problem, trying to eliminate the problem causing distress, which I think is important if we can do it. If you're stressed about money, you could get a second job, or you could get a different job, or you could make a budget, right? But we can't, if you're in debt, you can't get rid of debt in one day, unless you win the lottery or something like that. But you can't get rid of debt in one day. So how do we deal with these stressors ongoing? This is emotion-focused coping. Some of you might be familiar with the Serenity Prayer from AA. Alcoholics Anonymous says, God grant me the serenity to accept the things I cannot change, courage to change the things I can, and wisdom to know the difference. This is basically the message that we have a lot of times with our patients when it comes to like psychosocial variables. How do we kind of know the difference, and how do we treat the things that we can change, accept the things that we can't, by having a different perspective. From an emotion-focused coping standpoint, I talk a lot to patients. I show this slide to my patients as well. We can do distraction, okay? And I would ask you to think for a second, what are the pros and cons of distraction? Well, pros, right? You create some space from what's going on, right? Take a step back. But if we only use distraction, we never really deal with the problem. We distract, then we come back to the problem, we have to distract again. That's where eating comes in a lot of times, right? Substance use can come in as well, distraction. Food, I think in many instances, is a pleasurable distraction, right? It might fall into the second category as calming. Some people say food is calming to me, but we can do other things such as breathing or physical activity. There might be other activities that people find inherently calming, lighting a candle, sewing, whatever it might be. And then the last group, which I talk to patients a lot about, is processing. So journaling, prayer or meditation, talking to other people. On the journaling side, I encourage, there's a lot of data showing that gratitude journaling can be effective. Despite what I'm going through, this is what I'm thankful for. So that can be an effective way, kind of a short, and it doesn't require a lot of time. So if you're looking for things that patients might be able to do to help with processing what's going on, you might encourage them to try that. We have mindfulness. We have 3 pillars of mindfulness: present moment awareness, mind-body connection, and then acceptance and non-judgment. This overlaps some with CBT, but it is a bit different. Mindfulness is more accepting what's happening, staying focused despite the things. CBT, sometimes changing our thinking. Patients rarely get this last one at the base, acceptance and non-judgment. think this is really crucial in our patients to talk about acceptance and non-judgment. Some people say, well, if I accept it, I'm just going to stay at my current weight. And that's not necessary. We don't accept that we're going to stay here forever, but this is where I am now. I'm not going to judge it. With food, we can do non-judgmental approaches. I ate until my stomach felt full versus I ate like a pig. Your patients say that. Come in, oh, last night I ate like a pig. I'm so ashamed. It was terrible. I ate terribly. Versus I ate until I felt this way. When it comes to food, we can use mindfulness approaches. It's a non-judgmental awareness of our physical and emotional sensations associated with eating. I do a lot of mindfulness-based treatments in my groups. I actually have them like eat a food, and we do some grounding exercises, breathing before we eat. Think about where the food came from and be thankful for that food. Think about what they want to do with the energy of the food that they're going to have. Okay, so I'm thankful. I think about all the people that got this food to me. If it's a raisin, someone planted a grape, someone harvested the grapes, it was shipped to a store, all of those things. And there's some thankfulness for this. And then we use a lot of our senses. We look at the food, we describe it, we smell the food, we put it in our mouth without chewing and notice what happens. We recognize as we eat and swallow how our body feels. So these are techniques that I think are important in our, in our age of better treatments, that people are using their tool, their surgery or their medication, in order to pay attention. If we ignore the food, we're not going to have as much success. So in summary, psychosocial factors are important with all levels of obesity treatment. Improvement in mental health is common, but as I mentioned, sometimes it might move back towards baseline over time. Challenges persist with long-term weight management. I think that's obvious for anyone who works in the field. And we should consider the following long-term psychosocial treatment objectives. Identify and engineer our environments for success, so we're making it easier. Help patients understand the interaction between thoughts, emotions, and behaviors. Use both problem-focused and emotion-focused coping, and build skills and habits consistent with mindful eating. Thank you guys so much.
Thank you, David. Remember, you may ask your question through the Congress app. And now, I'm glad to introduce you Dr. Aurélie Bailot. She holds a PhD and is a kinesiologist and full professor at the Interdisciplinary School of Health at the Université du Québec on Ottawa, Canada. She holds a provincial research grant, Junior 2 FRQS, to lead a research program to optimize physical activity interventions across the 24-hour movement continuum in adults with severe obesity, with or without surgical treatment. She has conducted several pre-bariatric interventional studies on the effect of exercise training and physical activity counseling. She is the author of several systematic literature reviews on his topic. Her lecture is titled Importance of Physical Activity and Other Movement Behaviors in the New Area of Combined Therapies.
Good morning. Thank you very much for the introduction. It's a pleasure to be there today and to speak about the importance of physical activity and other movement. So I don't have disclosure for this presentation. So in the area of combining therapies and in an ideal world, we will have a full team of specialists with expertise to support the patient. And as you can see, there is a lot of piece in the puzzle. The full team of specialists can provide a large range of option therapies. However, in reality, it's quite different, and there is a lot of pieces that are missing when we support patients, and one of these pieces is often movement. And today I will speak about movement and why it's important to consider movement when we support patients before and after surgery or with obesity management medication. And I will start with the moderate vigorous physical activity. The American College of Sport Medicine and other experts recommend to include both aerobic and resistance moderate vigorous physical activity with metabolic and bariatric surgery and with obesity management medication. Why they recommend that is because moderate vigorous physical activity can optimize the effect of obesity management medication and bariatric surgery on cardiometabolic health and cardiopulmonary fitness, body composition, or quality of life. And they recommend that because moderate vigorous physical activity can also have additional effect of than bariatric surgery or obesity medical medicine on weight recurrence, muscle and quality and muscle strength, and also on bone health and functional capacity. You have these figures that illustrate what I was just saying before, that is a specific effect of moderate vigorous physical activity. As you can see, I don't know if it's, as you can see, where is it? As you can see there is a medication that have positive impact on adiposity, but don't have positive impact on lean mass. And if you follow the red line, the physical activity have a positive impact on lean mass, but also on muscle quality and function. And it results that it decreases sarcopenic-related chronic condition. And in addition, physical activity can have also positive impact, on non-weight related adipose-related chronic condition. That is the addition of the effect of moderate vigorous physical activity that is interesting to add with bariatric surgery or obesity management medicine. You have also this interesting study that speak about weight recurrence or weight regain. If you look at the blue line and red line, or blue column or red column, the blue is medicine only, and the red is medicine plus exercise. And you can see that there is a significant difference between the two groups for weight regain. So when we had exercise, the weight regain is lower than when we have only medication. So and the medication stopped 1 year ago. So the take-home message of moderate vigorous physical activity is in this paper. You can read this paper, it's very interesting. And what they conclude is that we that moderate vigorous physical activity have to have both components, so exercise that is resistance and aerobic training to provide the most optimal benefits for body composition and physical functioning in addition to weight loss therapies. However, moderate vigorous physical activity is only a small part of the day, and we all know that before and after surgery, the moderate vigorous physical activity level is low and remain low in the vast majority of patients. So what other option we can have to improve movement is that we can focus on other physical activity intensity. For example, you have light physical activity, and light physical activity is a more accessible and realistic intensity, and it's also a larger portion of the day. And in studies, there is a lot of study in adult population that show that light physical activity reduces the risk of long-term condition and mortality. What about studies in bariatric surgery patients? There is not a lot, but there is some study that assess that, and they found that there is a positive association with quality of life before surgery, and also with insulin sensitivity before and after surgery. So the integration of light physical activity in care of patient before and after surgery with or without medication is more realistic and sustainable approach to increase physical activity and improve long-term conditions. So it can be also an option. There is also another movement behavior that we can consider, that is sedentary behaviors. And sedentary behaviors, it's just any waking behavior characterized by an energy expenditure below or equivalent to 1.45 METs, while in a sitting or reclining or lying posture. For example, you are in sedentary behavior now because you are sitting and not really just listen to me. And so the sedentary behavior also a large part of the day. Unfortunately now, with the job we have, usually it's often in front of our computer, so we spend a lot of time sitting. So that is a large part of the day. And there is a lot of evidence that a reduced sedentary behavior can decrease whole cause of mortality in adult population. In metabolic and bariatric surgery population, there is more studies than for light physical activity, but the studies show, there is some controversy in study, but usually studies show that before surgery, a reduced sedentary behavior is associated with less severe obesity and better cardiometabolic health. And also that after surgery, the weight loss is higher and the weight recurrence is lower. And there is also the team of Dale Bound that show that higher sedentary time seems negatively influence appetite and eating regulation and quality of life. And we just did a scoping review on this topic on sedentary behavior and bariatric surgery. And if you are interested to know more about, you can go to read my e-poster. And if you don't, I take the opportunity to just present one figure of my e-poster, because this figure illustrates the topic of the paper, what they assess exactly in their paper. And as you can see, for example, in pink, there is like 57% of all the paper we include that assess the association between sedentary behavior and other factors. But the factors that was assessed was mainly anthropometric, so body weight. So we really need more study now about other factors like mental health factors, and we have to go beyond weight to better know what can be the impact of sedentary behavior. There is also another gaps in the sedentary behavior literature, that is intervention. There is only 2 interventions that have specifically target sedentary behavior after surgery. And in these 2 interventions, one is a 6 months behavioral intervention, and they don't find significant effect on sedentary behavior, but you have also the B-mobile intervention, that is an intervention of the Dale-Bound team, and they found a significant decrease in sedentary time of 15 minutes to 30 minutes per day. So I think that addressing sedentary behavior is important and represents an opportunity to increase activity level. So it can be an interesting option. And the last movement behavior is sleep, and an adequate sleep can, according to study, enhance the success of weight loss intervention, but also it can influence the results of moderate metabolic bariatric surgery and obesity management medication. And in MBS population, we have some study, and there is some discordance, but the majority of study are showing that improving sleep duration and quality seems to be correlated to the long-term weight loss follow. And so we also perform a scoping review on sleep and metabolic and bariatric surgery, and we hope this will be published soon. But here you can see the conclusion, that is that addressing a broader range of sleep dimension, that obesity sleep apnea, because there is a lot of literature on obstructive sleep apnea, that is good, there is recommendation, but we need also more than just obstructive sleep apnea. we need to also consider sleep regularity, sleep chronotype, sleep duration. And with all that, it could enhance a long-term result of the bariatric surgery or obesity management medication and patient well-being. So I just show you that all these behavior have positive impact of health, mobility, and mortality. That this approach, this previous approach that was used in paper, is I've been examining each behavior in isolation, not in an integrated approach. So I think that is important to have an integrated approach because there is codependency between movements, and a change in the amount of time spent in any one of these behavior will change the amount of time spent in another behavior. And if you change one, it can have different impact. For example, the benefits of physical activity are not the same if the activity is done at the expense of sleep or the expense of sedentary behavior. And that is why the silo approach just provides us an incomplete understanding. And you can answer to this question if you have a silo approach. That is why now we used in research this kind of analysis, that is a compositional isotemporal substitution analysis, where we can estimate the change of one behavior, what is the impact on if we change one behavior to another behavior. And in my knowledge, there is no study that was published in bariatric surgery patient with this kind of analysis, except that we will have one soon. They presented the result in previous congress, that is the result of Ying Wu and Lee Schumacher and Dalbon and all the team. And they tried to answer to this question with the data they had. Does HbA1c and early weight loss after bariatric surgery differ based on compositional time relocation between preoperative 24-hour movement behaviors? And their conclusion was that relocating 50 to 60 minutes per day of light physical activity or sedentary behavior to moderate vigorous physical activity was estimated to be related to a greater percentage of total weight loss, and relocating 15 to 60 minutes per day of sedentary behavior, light physical activity or sleep time was estimated to be related to a greater HbA1c change. So that is a good start, but we need really more now about a study with the 24-hour movement. And so there is, in my opinion, a lot of gaps in clinical and research about that. The first gap is probably the assessment. What is the best way? What are the recommendations to assess the three behaviors together? And for example, the validity of the question we use in accelerometer, the cutoff, and what is the best way to improve the compliance with the tool we used. Also, we don't have a description of, we have description of the change of moderate vigorous physical activity, light physical activity, etc., but we don't have the composition, how the composition changed before and after treatment, and also what are the outcomes that are associated with this composition. And as I presented you just before, beyond weight loss, we have to consider clinical relevant and patient-oriented outcome, not only weight loss, please. It's important to have more study about, for example, mental health. We need more experiment study to test the causality and to test also intervention modalities. We don't know how to intervene on all these behaviors. Is it better to do simultaneously together or sequential behavior intervention? What is the starting point? Maybe it's just the preference, patient preference. So we need to test that to know the better way to have an intervention. And also we have a lot of study on time and duration of this behavior, but we also have to consider the type, the quality, and the context. And it will be self-reported outcome. And finally, the 24-hour movement in the area of combined therapies. We have no idea of the impact of all this therapy and several outcomes. For example, if you have bariatric surgery and medication and movement intervention, what we can expect about that, and if we have also protein intake or creatine intake, what happened with all this therapy together. Probably it will be the best way to have good results, but also we have to think about the cost effectiveness. So we can have a lot of components, but in practice, in clinical practice, what will be the more effective and cost effectiveness too. So to conclude about this presentation, all movement matter and should be addressed, and shifting the focus of moderate rigorous physical activity for the 24-hour movement paradigm just will lead to a recognition that there is an interdependency between the movement, but also that provide more opportunity for intervention among individuals with different preference, different skill, and it will lead to superior health outcome. So that is a visual conceptualization of the 24-hour movement behavior using the 5S concept from pre to post MBS. We developed this figure, and we hope it will be published soon. We submitted that. It's more a conceptual paper, but it shows that there is a 24-hour movement before and after surgery. And you have the 5S because you have sleep, sweating, strengthening, stepping, light, and sitting, and that is before and after. And after, we decline, so the early post-operative phase and the later maintenance phase. And we don't have currently specific recommendation for these two specific phase, but there is more and more evidence about that. So just want to thank you, all of you for your attention, and let's finish now.
Thank you, Orly. We now continue with Joana Pino. She's a Chilean kinesiologist with a master's degree in sport medicine. She has over 20 years of experience working with individuals living with obesity and bariatric surgery patients. Throughout her career, she has designed and implemented pioneer exercise program in the major health care institution, becoming a national reference in the field. She has served as a lecturer in undergraduate and postgraduate programs, coordinated multidisciplinary physical activity and health teams, and contributed as an expert to the Chilean Ministry of Health in the development of clinical guidelines for exercise in chronic disease. Joana is also an active researcher and frequent present at national and international conferences. Currently, she developed her clinical practice at Quinete Mueve, Clínica Las Condes, and Centro Bio, while also engaging in academic work as a postgraduate lecturer at Universidad Finisterrae. Her motivation lies in promoting sustainable lifestyle change through physical activity, helping patients improve their health and quality of life. Her lecture is titled, Role of Early Muscular Activity After Metabolic Bariatric Surgery. Go ahead.
Thank you, Andrea. Hello, everyone. The topic I will present today is early metabolic rehabilitation. The body is designed to move. I want to explain what is the metabolic rehabilitation. Refers to a structured and progressive process aimed at restoring and optimizing the metabolic health of individuals affected by conditions such as obesity, insulin resistance, and metabolic syndrome, and type 2 diabetes. Condition in which excessive fat accumulation causes a disruption in energy metabolism, altering insulin level, blood glucose, and other related parameters. In this context, the muscle mass is very important. Skeletal muscle is not only essential for movement, posture, and strength. It also highly active metabolic and endocrine organ. Myokines, which are cytokine and peptides, secrete by muscle fibers during contraction. These molecules act as messengers communicating with other organs such as liver, adipose tissue, pancreas, bones, even the brain. Then the great challenge of the bariatric patient is attenuate muscle mass in the context caloric restriction, low protein intake, and catabolic status. Then it's very important considering the early exercise in these patients. In this study shows that during the first month following bariatric surgery, the muscle mass loss is equivalent the first month with the subsequent 11 months. The loss of muscle mass is directly associated with caloric restriction and the rate of weight loss. In this systematic review and meta-analysis on bariatric surgery patients reported that skeletal muscle, fat-free mass, and lean body mass declined most sharply during the first 3 months post-surgery, accounting for more than 55 of total 12-month loss, with over 8 kilograms lost by 1 year. Critically, the muscle loss correlates with decreased basal metabolic rate and a higher risk of weight regain, as muscle influence metabolic regulation and appetite signals. During caloric restriction for weight loss, the body uses not only fat stores, but also muscle tissue as an energy source. Studies indicate the muscle mass loss can represent 25 and 39 of total weight loss over a period of 36 to 72 weeks. Then in this context, produce sarcopenic obesity, postural alterations, and decreased strength. How early to start training? What do you think when I say exercise? The surgeon thinks, how is the patient go to exercise so soon? Let's better make sure and wait until a month. The kinesiologist thinks exercise is adaptable each condition. It is the tool we can introduce if it's guided by a specialist in this area. Physical exercise has multiple benefits for the bariatric patients. However, there are few studies on early exercise. In this review, only 3 studies out of 26 began with exercise prior to the month post-surgery. Of these 3 studies, 1 started exercise 5 days after surgery, and only 2 reported having performed muscle strength exercise. This study found a positive change in body weight as well in fat mass and muscle mass in the systematic review. Here I present our experience, which has been published in Obesity Surgery, where our intervention started 5 days after surgery. In this pilot study on the use of creatine, we first wanted to assess the tolerance supplement just a few days after surgery. It was a double-blind study in which the experimental group received 8 grams of creatine before training, while the placebo group received 8 grams constant. The training was strength-based and started between 7 to 15 days post-operative. As you can see, there are no difference in both groups. However, both groups that training lost than 10% muscle mass from total weight loss. In this other study, we aim to start exercise even early, but with exercise instruction rather than supervised sessions as in the previous study. Upon hospital discharge, patients were given a medium-resistant elastic band with a video with 8 strength exercise to be performed 3 times per week with 3 sets of 15 repetitions each. In addition, they were instructed to complete 30 minutes of walking of moderate intensity, evaluate using the modified Bohr scale, 3 to 5. They were also advised to avoid the Valsalva maneuver, and it was ensured that their protein intake was less 60 grams per day during the first month. The results show 1. Patients who achieved a protein intake 60 grams per day lost higher weight and fat, and patients who adhered to the exercise program increased both total fat loss, visceral fat loss. Since technology is here to stay, during the pandemic, we implemented online group training, which to this day has given us great results by reducing barriers of time and, in many cases, the feeling of exposure that our patients experience when attending unconventional gym. We therefore wanted to evaluate the feasibility, tolerance, and adverse effects in a group 67 patients who started exercise via Zoom between 5 to 15 days after surgery. The session lasted 50 minutes, 10 minutes warm up and mobility and general mobility, 35 minutes strength exercise using equipment such as elastic band, dumbbells, and body weight, performed in 3 sets of 12 to 15 repetitions with rest tolerate, and the 10 minutes countdown and stretching. The results showed that only a very small percentage reported discomfort, the most frequent being dizziness. This can be associated with episodes of orthostatic hypotension, which can be prevented by adjusting position changes and making a slower transition between exercise. Final reflections. Physical training in bariatric patients is essential to preserve muscle mass and enhance fat loss. It can be safely initiated early without complication. Also, some precautions are needed due to more frequent symptoms such as dizziness, nausea, and abdominal pain. Preoperative physiotherapy evaluation is indispensable for early initiation. By adjusting the exercise session, training can be performed at moderate intensity, which is the goal during the postoperative phase. Patient motivation and support are key for them to feel safe while exercising. Exercise also provides additional benefits that are perceived and evaluated by patients during the lifestyle change. Take-home message. Teamwork and trust are essential to generate new knowledge and improve the quality of care for patients, building on experience but always science-based. Thank you very much.
Thank you, Joanna. Please remember, you may ask your questions through the Congress app. Okay, now Dr. Creel, please go to the podium. Now he will present us the importance of dietary and eating behaviors in the new area of combined therapies.
All right, so I'm back again. So sorry you have to listen to me one more time. So yeah, please put your questions in the app. We're giving away a free car to the best question. So no, not really, but please ask a question so that we have some discussion. All right, so I'm going to talk a little bit about eating behaviors in the era of combined therapies. These are my kids. So my son on the left, my daughter here on the right, and they are runners. They're pretty into it. And sometimes they talk to me, they talk to their coaches about race strategy. So, how to, get out. If it's a big race, you don't want to get too far back, but also you don't want to go out too fast. And we talk about some of those things. But I would say race strategy for them is such a small component, maybe 2% of their success. What determines how well they do? It's their training, day in and day out. They race only a small percentage of the time. And I think we can use this analogy when it comes to weight management. So we spend a lot of time talking about the weight loss phase. What should we do during weight loss? How much protein? What kind of interventions? And I think as professionals, we think a lot about long-term, but we tend to focus a lot on these weight loss phases. And people kind of go in and out of these throughout their whole weight management journey. I think it's really important that we spend more time and we promote these blue areas, so to speak, to help patients. Just like my kids aren't going to focus on race strategy in lieu of kind of day in and day out training. So people are typically, when they're in the weight loss phase, they're motivated. So those things with high motivation might not be as realistic for them as some other things kind of as their life continues beyond that weight loss phase. So I'm going to talk a little bit about some things related to this new era. It's going to be kind of a general talk. And again, ask some specific questions in our chat area. So this new era, I would say I'm excited and troubled a bit, right? I'm excited that we have more options. I'm excited for our patients who have battled with the disease of obesity for so long. I'm very, very excited that we have treatments beyond metabolic and bariatric surgery, and that our surgeries are getting better and better, and that we can combine therapies. I'm very excited about that. Just like I'm excited about new technology that can detect and treat cancer, right? At the same time, if we detect and treat cancer, but we don't look at some of the behaviors that are associated with it, like smoking, I think we're kind of missing the point. And I'm concerned about some of the eating behaviors as well. How much time are we talking about the healthy eating and promoting it, creating environments for healthy eating? Okay. So some problems as I see it are foods, our attitudes towards foods, maybe this treatment versus prevention. I think that we have to make sure that our society, our medical groups are still focusing on prevention. And I think in our practices, even though we treat obesity, I think we need to think about prevention. Not just prevention of developing obesity, but prevention of class 1 obesity becoming class 2 or class 3 obesity. Because what we know is that once someone develops obesity at different levels, the body defends that. So I think prevention is really important. Our approaches are going to be systemic, right? Sometimes you read the weight gain prevention research and we tried this and there was no statistical difference. We tried this and it didn't do much. It's like a drop in the bucket. But I think we have to realize that we have to work on a lot of things together, and these things might interact and be synergistic. With our one-on-one contact, talking about personal importance of weight management, I think is very, very useful because this is hard work in the environment that we live in. So creating this desire to do things for the other values in their lives. Making the healthiest choices the easiest choices. I was on a committee many years ago with one of our state associations, and that was just the drive. How can we make the healthiest choices the easiest choices? In our environment as a whole, as a society and governments, how do we make the healthiest choices the easiest? Also in our recommendations. If we provide recommendations to people that aren't realistic, they're not easier, then they're not going to be able to do this as well, or it's going to require a lot of dedication and motivation. We want to make it easier. And we want to focus on mindful eating, which I talked about a little bit earlier, becoming more mindful eaters. I think sometimes people from other countries like, oh, I went to America, everyone's eating in their car, it's different, right? But being more mindful eaters can really help us in our management of weight over time. Ultra-processed foods, it's a big item. This is a Hallmark study published by Kevin Hall and colleagues showing that when you match macronutrients, okay, diets that have equal macronutrients, carbohydrate, protein, and fat, kind of natural diet, unprocessed versus processed, people, they were in a laboratory for 2 weeks, so measuring everything, highly controlled, short-term but highly controlled, and the people ate more calories on the ultra-processed diet, okay, and they actually gained weight in that 2 weeks. Why? Why does that happen? Well, they noted that they ate more grams per minute, so more volume per minute, so they were eating more quickly, and they ate more calories per minute as well. So that makes us start to think, well, are all ultra-processed foods the same? Right? I had one of the naked bars the other day. You know the naked bars? You know, all the fruit and stuff, and I think that's different than a candy bar, but what does the research show? So this study compared ultra-processed or minimally processed diets, but the ultra-processed met the dietary guidelines. I think this was a study in the UK, actually. And then they did a crossover design. So 2 weeks of baseline, 8 weeks of the ultra-processed, 4 weeks washout, 2 weeks baseline, 8 weeks of the minimally processed, or vice versa. And what did they find? Well, they found that participants lost weight on both diets. They kind of had they provided the food more than what they could eat and said, eat as much of this as you want. There was some structure to it, so they lost weight. But they lost more weight with the minimally processed. So, yes, ultra-processed foods I think are important, but we have a lot to learn. Are all ultra-processed foods the same? If I mash up fruit and vegetables and I put it in a blender with protein, yeah, it's highly processed. Nothing's in its original form, but is that the same as eating, white flour, white sugar with fat like in a donut, right? Is that the same? I would argue probably not. So we have the NOVA classification for ultra-processed foods. Maybe this is a good classification, but there's some nuance to it. We need to kind of think about what this means, or maybe we need a different classification. So what do we want to consider? What does the research kind of say? What are some of the factors that can impact the calories that we consume? What are some factors maybe that we didn't look at, or Dr. Hall didn't look at in his original study? So palatability seems to be a big factor. So the better a food tastes, the more we tend to eat. And foods that are not kind of grown on a tree or grown out of the ground or in an animal, we put these ingredients together. What are the ingredients that tend to make foods more palatable? Fat, sugar, salt, right? We put these things. Think about it. There are very few foods that have a lot of fat and carbohydrate together in nature. Kind of think about what food in nature has a lot of fat and a lot of carbohydrate. Not many, right? Think of one that we want to have a lot of when we're young is breast milk, right? But beyond that, there are not a lot of foods. So we're creating these foods, we're processing these foods, and we need to kind of consider those things. Protein content. We know that protein is a bit more satiating than the other macronutrients, and it also has a higher thermic effect, okay, on our bodies. So it takes more energy to digest and absorb protein. Fiber slows gastric emptying, helps us feel more full, and a lot of times fibrous foods require more chewing. They tend to be healthier in general. Chewing is a big factor. We've seen this in studies where the foods that you have to chew, eating an apple versus applesauce versus apple juice, for instance, which one are you more likely to consume more of. Or if we do this as a preload before a dinner, I eat 2 apples versus I drink a glass of orange juice or I have applesauce, I'll tend to eat more, if I have the fluid than if I've chewed the food. Okay. So the question is this progress? All right? Is this progress? I don't know. You could answer this in a lot of different ways, I guess. It might be progress if it helps people. I had a Freudian slip. I said it might be process. It might be process, yeah. So this might be progress. We're eating less. It might help us manage our weight. But is it really meeting our long-term goals? So obviously what we're shooting for is a more balanced diet, one that's more whole foods, less processed foods in general. What does the CDC, Centers for Disease Control, this is before some changes at our CDC, but addressing obesity requires organizations and people to work together to create communities, environments, and systems that support healthy, active lifestyles for all. I think this is important, not just a treatment model, but creating lifestyles and everyone working together. So I think it's nice that we have treatments now, better treatments even for teens. How many of you anybody work with adolescents? Okay. It's tough being an adolescent in general. It's even tougher being an adolescent with excess weight. It's a really rough environment. Kids can be brutal, and I'm glad we have treatments. However, what we don't want to have is, from an early age, more and more people just being treated with medications if we can prevent it. Right? That makes sense. If we can prevent it through lifestyle change and create an environment, it makes sense. That's one of my concerns is, where are we going if we don't continue to make changes in the environments and are promoting a healthy message versus a treatment message only. So what do we know? If we're talking about what to do, there's a lot of debate, and patients are really, they have their silos. Even professionals have their silos. You just get on social media, right? The low-carb people, the low-fat people, the 2 grams per kilogram protein per day people. You see lots of things. But what does some of the literature show? So Chris Gardner at Stanford published a paper several years back looking at, they tried to have a ketogenic diet versus a low-fat diet. What they found is they had a low-carbohydrate diet versus a low-fat diet because people weren't really in ketosis, probably hitting that level. But they looked at outcomes over a year. No difference between the groups. What they did find with some sub-analyses were that people who were adherent to the plan lost more weight, right? So adherence is a big deal, right? Weight loss improves almost all obesity-related conditions. Individuals are going to vary in their preferences and ability to adhere to diets, and we have to focus on that adherence piece. This is not a profession where we kind of demand and we need to get in our silos. We need to talk to our patients. There are different ways to help people manage weight in a healthy fashion. This was, anybody from Spain? Yes, very good. Welcome. This is a study with 23 centers in Spain looking at the Mediterranean diet, which the Mediterranean diet gets really high marks. It's kind of the best diet. And you hear of DASH diet, but folks in the Mediterranean seem to know things, right? So they looked at the Mediterranean diet, prescribing this versus a reduced calories. So we're going to modify this a little bit to help you reduce the calories, plus physical activity, plus professional support. And what they showed is that when you add these components, you do better. So the messaging can't just be general. We have to kind of dig in and look at the other components. So when you're talking to patients about, obviously, their diet, we want to talk about what other kind of support do you need? How can we still manage calories? Are you drinking olive oil? If you're drinking olive oil, we might not get the results that you want, right? If you're using olive oil and eating nuts, that's good. So this study was published from data from the Nurses' Health Study, the Women in Nurses Health Study 2, and Men in the Health Professionals Follow-Up Study. This is just looking at carbohydrates, okay? So carbohydrates, among many of our patients, they're viewed as evil, right? And then they find, oh, I can't eat carbohydrates. When I start, if I eat fruit, then I've kind of broken this rule, and now I'm eating more carbohydrates that it's not fruit anymore. Now it's chocolate, and now it's whatever it might be. So when we look at these data, these long-term data and weight changes, when you eat more non-starchy vegetables, which are primarily carbohydrate, if you look at, the package of broccoli, doesn't have a lot of carbohydrate, but it's primarily carbohydrate. The more people eat of those, the more their weight goes down over time. The more fiber in the food, more the weight goes down. But, to no surprise, more added sugar, more starch increases weight. Now, the following, carbohydrates from starchy vegetables. This is the common question. If you look at this study, most of these were from potatoes, okay? I don't think potatoes are evil, but what kind of potatoes do you think people were having? Fried potatoes of some sort, right? So we have to take this with a grain of salt, that probably most of these were not just in their natural form. Even when we look at bariatric surgery, metabolic and bariatric surgery, Wendy King published a paper several years ago looking at some of the factors that lead to weight recurrence. And these are the factors that came up. So even with our most powerful interventions, eating fast food at least 2 times per week, eating when full at least weekly. So as I was talking about earlier, being a mindful eater, if we're not being very mindful and we even have these most powerful, mechanisms to reduce our intake, it's not going to work as well. Grazing, so continuous eating throughout the day. How many of you are seeing grazing with your GLP-1 patients? This being a problem. Anybody noticing people? How many of you work with patients on the obesity management medications? Okay, not a lot. Is that some? Okay, all right. I'm starting to see this quite a bit with some of my patients. Sometimes it's because they are told they need to eat more, and they just can't eat a lot at one time. Sometimes it's so they get full really fast, and they're just grazing throughout the day. Sometimes it's like certain foods, just like with metabolic and bariatric surgery. I don't really want protein, so I'm eating these carbs, and that doesn't really satisfy me, and I eat throughout the day. Not weighing at least weekly. So as a dietitian, as a psychologist, I have this discussion a lot with people. And what do the data show about weighing? Most of the data show that people who lose weight and keep it off tend to be regular weighers. When we look at people who are randomly assigned to weighing versus not weighing, people tend to do better. Are there exceptions? Absolutely. All right. Sometimes people with an active eating disorder, we're not promoting weighing or not weighing in the same way. Okay. But really being able to identify what you're doing and how it's impacting your weight over time, I think is important. So I often have the conversation. If you have diabetes and seeing high numbers kind of freaks you out, do you just not check your blood sugars? You just take off your CGM? No, right? We learn ways to kind of pay attention to this in a healthy way to modify our behaviors. So I think the same thing is important with the scale, and it's a very important discussion to have with people. If they're trending in the wrong direction, kind of take a mindful approach without judgment, look at what they're doing, not using one weight to judge anything, looking at trends. We actually have some scales that do this. So there's a scale, and I have no vested interest in it. It's called SHAPA, S-H-A-P-A, and you weigh for like a week, and it kind of gets your baseline and kind of how much you vary in your weight. And then after that, it just shows up in colors. Are you trending the same? Are you going up? Are you going down? And for some patients that want the monitoring without the numbers, we will do that. In the US, we're not on the metric system, so I tell people to weigh in kilograms. And if they weigh 100 kilograms, I say 100 something, that's good for them. So sometimes we can kind of play with the scale if we're using kilograms versus pounds. And then again, with this study, the highest quartile of sedentary behavior. All of these together led to 20.7% more weight regain or weight recurrence. What about GLP-1s? So this slide, I'm guessing in a couple of years, this is going to be a dated slide showing that over 50% of people stopped using GLP-1s within a year. Well, why did it show this? Well, have a lot of things going on. Access issues, cost issues, we have side effect issues. My guess, over time, these medications will get less expensive. It's going to take a while. I think our physicians hopefully are going to get better at titrating and knowing when to kind of stop people or ramp them back down if they're having side effects, right? So I think these will change. The access is hopefully going to improve. But the point is, no matter if these numbers go down, we're going to have people cycling on and off of medications. Okay? Whether they've had surgery or not, they're going to cycle on and off for various reasons. And I think we need to help people prepare to manage their weight without medication. So if we're relying only on the medication, it's not going to work very well. I have patients all the time say, I have patients that are paying out of pocket. I'm not going to be able to continue this. I know I'm not, but I wanted to get the weight off. What do I do? Well, I mean, the best case scenario is we would stay on the medication, but they're saying, I can't, right? So maybe they take a different medication. But what I talk to them about is, let's create a system. Let's create an approach to your eating that will carry over even if you don't have quite the appetite regulation. The planning, are you planning your meals? Are you eating on a schedule? What types of foods are you eating? Are you eating less processed foods? Where does physical activity fit in? Let's develop a system while you're losing weight so that it becomes more habitual. So I think those systems with patients are very, very important. We all have routines that can be really helpful. We don't have to think as much when we have a routine. So using that approach can be very useful. So in summary, eating behaviors are essential for health, no matter the power of the medical weight loss intervention. Weight management is going to consist of fluctuations in weight that I think we can really minimize with lifestyle change and consistent approaches to eating. Viewing food as fuel for physical activity is important. When somebody gets turned on to physical activity, they're eating because they want to feel good when they exercise. I want to feel good taking that walk or hiking or biking or whatever it might be. Takes on a new role, food does, versus food for entertainment. Nutrition has independent effects on health, like cardiovascular disease, bone health, et cetera. Sometimes we forget that. We're in the weight management field, like, how is this going to impact weight management? We have to consider, how's it going to impact health overall? Minimally processed foods and carefully selected processed foods can yield benefits. And our recommendations are only as good as the patient's willingness and ability to incorporate them. So thank you guys so much. We are going to open it up for questions. All right.
Okay, we are now start the question and answer time. We have a question for Oriana. She said, how soon bariatric patients have to start physical activity and what exercise can they do? Example, thank you.
Thank you very much. I'm convinced the body is designed to move. Then the first week post-operative, begin the walk every day, and after a control surgeon, begin a strength exercise without abdominal work.
Okay, Aurelie? You have to.
Yeah. So, in a movement perspective, it's just that after the day of surgery, we can just start with reducing sedentary behavior, just to get up, and yes, we can start with walking the day after surgery. So we can start movement, that is not exactly exercise, but movement the day after surgery. And we will hope to have less complication, post-surgery complication with that, and less time in the hospital. And after, yes, resistance training can be introduced during the first months. I totally agree. And maybe abdominal exercise have to be checked with the surgeon if it's okay to start abdominal exercise. But after the day after, we can start to move, and that is the optimal solution for me.
Okay, David?
So it's a great question. I think I'll just kind of add maybe to what the other speakers have said, that if we are doing physical activity leading up to metabolic and bariatric surgery, I think that transition is a little bit easier. So the more fit they are, the more easily they are able to do those things. I think there are some things we have to consider. Sometimes our surgeons are doing a hernia repair during the surgery, and we have to take that into consideration as far as healing. But I agree that walking should be the first thing that we do, and once those internal incisions have healed, then strength training becomes a better thing to incorporate at that time. Obviously, pool exercise is great, but we want to make sure for all the nurses and that those adhesions or those the scars have healed before they get into the water.
Okay, thank you. David, there is a question for you from Marcela. She said, David, do you believe prevention will be harder and even forgotten in this new area of obesity treatment? Patients may believe that if they gain weight, they can use medication and or get metabolic bariatric surgery.
This is a really good question. Thank you for whoever asked that. I actually asked the same question in a session yesterday with some of our obesity medicine physicians. I don't know what's going to happen. My hope is that adults will take these medications and they will improve their diets of the family. And so their kids will start to understand this is a healthier way to eat. Maybe I'm being overly optimistic, but I think part of this is our responsibility as providers to talk about the systems of weight management, making things practical for families, because truly the kids are the ones who are going to be affected over time. And if we can prevent childhood obesity, it's going to help prevent adult obesity. So talking about the way we eat, but also the physical activity piece. We know that physical activity is protective from a prevention standpoint. So incorporating both of those things. But to answer your question, I don't know what's going to happen, but my hope is by having more attention on this, people feeling more hopeful that people will change their eating. I don't know what people are telling you, but many people on the GLP-1s are telling me they actually desire more healthy foods. Not all people, but there are many people who say that. Maybe it's psychological because they're losing weight and they think, oh yeah, this is what I'm doing, and there's kind of this association. But some people tell me they don't crave some of those foods as much anymore, and it's easier to say no to them.
I just want to add some reflection, and I think it can maybe happen if that is the only option that is present to patient. Oh yes, you have bariatric surgery and medication, but no, that's not true. If you see the whole option therapy and you say that, yes, that is one option and it can help you, but that is not the only way you have to consider. If you are taking this option, you have also to manage your daily lifestyle or your health behavior. It can be the only solution to manage obesity. So the full team of specialists is really important with medication and bariatric surgery, because that is not the solution, and that is a mean and another tool, an option to help people. So if it's the presentation of this solution are like that, maybe we'll prevent some.
Joanna.
I think the obesity is a complex disease. In this context, the challenge is change the lifestyle, but is ever será necesario. Siempre será necesario.
Will be ever necessary?
Will be ever necessary to do.
Okay. We have another question from Mary O'Kane. Aquí. With metabolic bariatric surgery, we focus on health improvement and realistic weight target and behaviors change. There is risk that OMM can raise expectation that people can and should achieve a BMI of 25. Sorry.
It's a good question. I think this is where, as providers, we need to educate patients. When we look at weight loss with the current OMMs, maybe 20% with tirzepatide, maybe 15% with semaglutide. People with diabetes tend to lose less weight. Having these conversations about what's realistic for them, I think, is really important. Not only what's realistic, but sometimes reshaping what might even be optimal. We rarely see our metabolic and bariatric surgery patients get into, have a BMI of 25 or less. And if they do, some of those patients are sick. They're not tolerating things well. So it's very common for people to have optimal health after they've come down from a high weight, to have optimal health at BMIs that are considered in the, quote, obese range. Because the BMI standards were based on kind of the general population, not people who had come down in weight. So I think we have to have that conversation, and it needs to be consistent among all of the providers. Obviously, people want to lose more weight. People who lose a lot of weight, they have excess skin. And I talk to them, they don't like the excess skin. It's like, do you think that that's causing problems metabolically? I know it might be causing some other problems, but that is not causing problems metabolically. I don't know if anyone went to the talk yesterday showing sometimes the pannus that is removed from patients. That is extra weight that is not harmful from a metabolic standpoint.
Okay. What do you think is the most important characteristic trait from the behavior perspective that allows people keep their lifestyle change?
Thank you for the question. Probably to choose some change that you can keep, that you can have during all your life. Sorry for my English this morning. But it just, you have to choose change that you can sustain. That is what can be probably more helpful. If you can just reduce, if you prefer to walk, you will not start to run, because you can start to run, but you will stop and just quit because you don't like that. And so I think the best way probably to keep the lifestyle changes is to choose what you can sustain on a long time.
It's a great question again. Sometimes I think about traits as something that people can't change. It's kind of their trait, and sometimes people are kind of dealing with their traits. But I think in the real world, we meet people that have certain characteristics, and we kind of work with those, right? So some people, I'll be honest, when I have patients that struggle with ADHD, for instance, they struggle with organization. So we have to really work in a different way with them. Self-monitoring with someone with ADHD can be really challenging sometimes. So we might talk about self-monitoring in a different way. Can we have a little checklist versus writing down everything that you're eating, right? So traits, I think conscientiousness is something that is considered kind of a personality trait, and that's important. But again, understanding the patient and what their challenges are, being open about that. But just like that, people with ADHD are very gregarious a lot of times. They like socializing. So we talk about either physical activity or nutrition that incorporates those things, getting support from others, because they're not generating some of that executive functioning they struggle with. So to answer your question, I think to Aurelie's point, but we have, we want people who can find things that they can do long term, but also kind of understanding what their personality is like and seeing if we can work with that. Asking them, I ask them a lot of times, how can I help you best? Coach me to coach you. And so I think that is always, can be an effective question with patients who know themselves better than we know them.
I think the people when find the new motivation in their life. The motivation is very important when you want a change in your life. Then the people, it's necessary, all the professionals ask the people which is your motivation. Then it's very important for the process.
How do you recommend measured fluctuation in muscle mass and body fat during rapid weight loss?
I think this is a really good question, and I think we have a lot of limitations with what we use, right? And I think several people have spoken about this. I see Dr. Aquino here spoke about this yesterday as well. But we have to look at how good our measures are, and sometimes our measures really haven't been validated in the population of people that we're looking at. So I think we need to look at function as much, probably more, than we're looking at just changes in body composition. We know that with rapid weight loss, probably no matter what you do, you're going to lose a significant amount of lean tissue. And we don't know what that lean tissue always is, or this fat-free mass exactly is, because our measurements aren't good enough to detect it. But I think focusing on function is really important. And looking at what they're doing from a nutrition standpoint, if they're eating a healthy diet, adequate protein, their function is good, I think we don't spend as much time paying attention to some of these numbers, versus if it all makes sense, we can kind of show the patient and use it as an education tool.
Thank you. I totally agree with that. And I think that we have to, yes, we can assess the quantity, but what is more important is the quality of the muscle, and that translates to the functionality of, finally, we know that patient will lose lean mass and muscle mass, but if there are a good functionality, I think it's fine. So it's just to go beyond the quantity and just focus on the quality and the functionality of the muscle.
And there is any association between the muscle mass loss and the functional capacity?
That is a question that I asked myself before the panel, and I really don't know, because we know that in your presentation we see that there is a decrease in muscle lean mass that is correlated with resting metabolic system and with weight regain, but I don't know at which point it is correlated with functional capacity. And I have no idea, and I was thinking about that during your presentation, and I have no study in mind about that, so maybe someone have, but I don't have, and it can be interesting to know where if there is a correlation and where is a point where muscle mass is the loss of muscle mass.
The correlation weight relationate with the with the levels of irisin, and myokines relate with the appetite, and the brown fat, oxidation fat. Then I think functionality is important in the strength, in this cardiorespiratory fitness, but the muscle mass nowadays have other function directly with appetite signals. For the others, peptides secreted when fiber contractions. I think it's important quantity and quality, but few studies talk about this topic.
And exercise training, post-surgery exercise training with muscle training, with resistance training, we can see that usually there is lean body mass reduction, but strength, they can maintain the strength, so it just sometimes, even if you have a decrease in quantity, the functionality or the strength can remain stable, just what I have in mind.
I think the other thing when we use this word function, we have to consider what we mean by this. So we often measure function with strength. That's not the only thing. But are we talking about absolute strength, or are we talking about relative strength? So relative strength is like, can I get up out of my chair? Can I get up off the floor? And relative strength in most instances tends to be the most related to kind of quality of life. Now, most of our patients, say that you lose 100 pounds and someone asks you to help them push your car out of the ditch, they might not be able to do that as well. That's absolute strength. But relative strength, we want them to be stronger in their new body than they were in their old body. And so I think that's an important thing to consider, not just, oh, your hand grip went down a little bit. Well, how's that? Well, hand grip's maybe not the best measure, but your chest press went down a little bit, or your squatting ability went down a little bit. Well, how does that relate to your new body? So I think that's an important consideration, not to dismiss that sarcopenia is a real problem, but at the same time, we have to keep this into context with when we see these changes in strength. Are they absolute changes, or are they relative changes?
In your experience, is there a normal amount of muscle mass loss in the initial phase after bariatric metabolic surgery with appropriate nutrition and physical activity guidelines?
The initial restriction is greater. Then it's normal, but it's bad. It's not bad. Then with intake protein and exercise, you can decrease, but no nada, o sea, no perder nada. Es que no se puede perder nada.
It's not significantly.
It's not significantly. You can decrease, but it's not significantly. The first month is very difficult retener.
To gain?
No gain, retener. How do you say retener? Maintains muscle mass. It's impossible. That with the protein intake and exercise, you can help.
I don't think we don't have any norms, and I think it also speaks to how we measure it. We don't know what's normal. We don't know what's problematic necessarily, and it's probably going to vary from patient to patient, probably based on the amount of muscle they had to begin with. Some people have more, they're more muscular, and it's not going to affect their quality of life as much as others. If you have surgery, if someone who, a 70-year-old woman has surgery and has already low muscle mass or something like that, we're probably going to be more concerned about a 30% loss in lean tissue than someone, a 35-year-old man who can still function pretty well.
Do you have any thought on weight cycle with GLP-1? My experience is that another treatment period is less powerful. That means the more often you start and stop, the weaker the effects over time. Comments?
No comments.
Now, there was a nice talk yesterday on weight cycling, right? Would you like to say something? Do we have a microphone for her?
Sorry, I don't know exactly what is the question about a weight cycling. You can repeat the question, please?
Rejan, do you have any thought?
Sorry, I can repeat my question. So the question was, my experience is that people on GLP-1, starting, finishing, they have less effect the more often they try.
The more often?
The more often they start again with GLP-1.
But before the bariatric surgery, after or during the...
It doesn't matter. Because it doesn't matter. So they are on weight cycling due to, they are on and off. And I think this is a trend, or this is, I see a risk that this is a trend we will see, which gives us, or me as a bariatric surgeon, a chance to do operations on these patients, because all the effects we see with GLP-1, it's exactly the same as a usual diet. You try, you fail, you stop, you try again, you are on a higher point of weight, and I think the non-adherence is a huge problem that we have to face and that we have to handle.
So just I'll summarize your question and make sure I understood it correctly for the audience, that with the weight loss medications, people sometimes are on and off of them. They're weight cycling. As a bariatric surgeon, he says this is an opportunity to maybe talk about something that's more permanent. You don't take the surgery away once you do it, but what is the effect of this weight cycling maybe on health? Should we be concerned with people are going on and off the medications, gaining weight, losing weight?
So it's important to stimulate that reduce the weight, stimulate for reduce the weight. But I review in some article that if you stimulate the reduce the weight and you don't continue this treatment, you reduce the metabolic, the parameters, the cardiometabolic parameters, but when these patients increase the weight, it return this problem. So some articles question, if you stimulate the patients before bariatric or after bariatric, these patients reduce the weight, and you don't continue this treatment, are you a good health for these patients or not? I don't know if I understand my question. Because when you interrupt the treatment, you decrease the health of these patients. You understand me? That you reduce the health of these patients. So what's important for weight cycling? The continued treatment, regardless the medications or bariatric surgery or the continued treatment, and the exercise and the changes in the lifestyle is important, is necessary a multidisciplinary team. Because if the treatment, just continue this treatment if this patient is followed. If you don't follow, stop the treatment and receive the weight and the other problems. I don't know if you...
No, thank you. Thank you so much, Rajan. So I think there are things we don't know about weight cycling still. I think one question that I have is weight cycling is harmful if physical activity is consistent within the weight cycling. I don't think we know that answer. I think most of the studies would say it's better to weight cycle than not lose the excess weight that you have. But she gave such a nice presentation yesterday showing that there probably are risks associated with this up and down changes in body composition. There are from what I see, there are psychological indications. It's like people are expecting to have this weight cycle. So in the presentation, I was talking about really trying to have these approaches to eating and physical activity that stay really consistent, even if you're not on the medication, to kind of mitigate those fluctuations.
Thanks. The patient says that making exercise increases the appetite. Is this true or not?
I think it depends. Exercise, prolonged and moderate intensity, deplete of carbohydrate reserve, then increase the appetite. But heat, for example, inhibit the appetite, but the evidence is not conclusive.
Okay.
I try to remember the conclusion of meta-analysis on this topic, and I know that there is no more energy intake with exercise, but I also know there is a lot of variability between patients. So probably for some patients it could happen, but when we look at meta-analysis results, probably there is no significant impact. But maybe we can have some patients that can relate that, and probably you can try to find some solution to do maybe exercise after eating, or but I think that there is no significant effect on that, but there is a lot of variability.
There are also some older studies looking at lifestyles, and what we seem to see is the more sedentary we are, the more there's a disconnect between our needs, or what our body needs, and how much we want to eat. So to your point, I think it's going to depend on the person a lot, but it also may depend on the level of physical activity. So being sedentary causes this disconnect sometime with appetite. Moderate physical activity, my understanding is yours, is that we don't see a large effect. But then if you have a lot of activity, athletes are not, whittling away, right? They're highly active, and they have a close connection to what their body needs, and they regulate their weight well at a leaner body composition. So I think moderate physical activity usually doesn't have an impact. But I would not challenge my patient. If she says, this is what I'm feeling, I would say, true, this is what you're going through. I would look at timing. Sometimes what happens is the person says, I said, what time are you exercising? I exercise at 5. What time are you eating dinner before? Oh, at 5:30. So now dinner's at 7, and she's really, really hungry. So I think we have to look at some of those nuances in the lifestyle, maybe having a snack. Maybe that she really doesn't feel like she needs more calories, but it's the timing of her eating that's really making a big difference.
Did the study showing no negative impact of mental health during after GLPs differentiate between those receiving the prescription at PCP or, sorry. Ooh. No, we lost the question.
Maybe the person can ask the question.
Okay. Okay, again. Again, yeah.
So the question is, did the study showing no negative impact on mental health during or after GLPs differentiate between those receiving this prescription at the PCP or med spa versus a comprehensive program? Do you know any active studies contrasting outcomes between the two? That's a really good question. This was this was a review or a meta-analysis, so it was looking at lots of different studies, and off the top of my head, I can't remember the criteria for including those studies, but usually when we have reviews or umbrella reviews, you do lose some specificity with kind of those things, and that requires these other more specific randomized controlled trials. I don't know if you would have anything to add to that. Yeah. But, you know, I would think that, you know, the more support you have, the better people are going to do mental health-wise. So depending on, it's not always where it's delivered, but how it's delivered at that place. So. I had a question for the group. So yesterday, we heard about bimagrumab. I can't say that word very well, but it's a newer medication that's being tested, phase 3 trials, I believe, which will cause some weight loss and help us maintain muscle loss, maintain muscle during the weight loss phase, maybe even increase muscle. To my fellow exercise physiologists, what do you think? Are we going to say, if we have this medication, maybe resistance training isn't that important? Maybe you say, let's do cardiovascular training, because you're not losing muscle. You look good muscle-wise, right? What do you guys think if this medication is approved and people start using it?
I think that resistance training can have also other impact than just muscle quantity. So it's really important to keep resistance training, even if your lean mass or muscle mass is maintained. So you can probably have functionality that also can be trained. And yes, I think both aerobic and resistance training are important, because with endurance training, you can improve the vascular component of the muscle, you can increase mitochondrial muscle content. So both are important, and that is not because you maintain your muscle mass that you don't have to train your muscle mass.
Do you have something to add, Joanna?
It's not only quantity, it's very important quality and functionality. Then this condition not better with pharmaco.
Do we have other questions?
I have maybe a question for you. It was, you speak about psychosocial impact or importance, but I don't see about weight bias. And I'm asking, we see that usually bariatric surgery is seen as an easy solution, and there is a lot of stigma on that. But do we know if it's with obesity medication management or medication, yes, it's the same, and patients have also weight bias and will be stigmatized because they are taking medication and they want to say that? And what is the impact of that?
Thanks for asking a tough question. I haven't seen much data. I'm not saying it's not out there. I haven't seen much data on weight bias specifically with GLP-1s. But I think we can really apply the information that we have with metabolic and bariatric surgery and people with severe obesity. 2 types of main weight bias: internal weight bias, so how people feel about themselves, which we know if they have negative feelings about themselves, this negatively impacts their outcomes. Some people think, well, if I feel bad enough about myself, then I will change. And what the research really shows is it's kind of the opposite. The worse you feel about yourself, when you have a little setback, you stop, you get very depressed possibly. So we have internal weight bias, and then we have external weight bias. I think that we see a lot of this with severe obesity, people being treated poorly. There's a lot of social media around Ozempic face, all of these things, people taking the easy way out. And I can't imagine that this is helpful in any way, shape, or form, just like it's not helpful when people say you took the easy way out and had metabolic and bariatric surgery. I would anticipate we're going to see similar results, but I haven't seen any of those data. I have a couple. Yeah, okay. We just have a few more minutes. I guess one question that I have for the group, and I think to me it's important. We talked a little bit about body composition, but I think the messaging around body composition is important. So from the different disciplines, I guess from exercise physiology, what do you think, how do you talk to patients about their body composition readings in a way that not only is like, oh, we can see this, but is helpful for the patient? Because, and maybe some pitfalls that you see with using body composition more than just using the scale. Did you understand my question?
Yeah, well, I'm not sure. It's just how to address the, if they want to assess assess body composition often, if it's I'm not sure about the.
Do you feel like doing this could be problematic? Are there problems associated with talking to people about their body composition? Do you see any potential problems with that?
Probably less than weight, because we know that weight is not always related to health, but yes, body composition maybe is a way to go beyond just weight, because it provides more information about the health. If we decide to assess that, it's important, yes, to explain what it means, and probably, depending on the tool we want to use, what is the validity of the tools. And yes, it reflects, but at an individual level, maybe the change can be captured. So it's just to, if you want to use that, is to speak about the validity of the tools and what it means, but also, again, to speak about the quality is probably more important than the quantity. So the focus is not maybe, I want to have this percentage of lean body mass, but maybe more, oh, I want to have, I want to be able to take the stair, or it's maybe more realistic functionality that to have this number of the scale.
In my clinical practice, I talk with my patient the body composition related with health. Then not weight, is body composition, is function, is health, is inclined, imagine, self-esteem too.
No, thank you guys. I've just had some experiences where it was actually with a physician many years ago who shared information to a patient. She said, you know, you're losing, you lost this much weight, but you've lost muscle. So something you're doing isn't working. So I think, to your point, really understanding what we can expect and the validity of the scale and combining it is important, because I think, to me, say, oh, we have these better tools, and now we want to make it a bigger deal than the scale. I think we could have some concerns. Some patients they're much more probably concerned about how they're functioning. So I agree with you guys. I had one last question for the group, and then we'll finish. This new era of treatment of obesity, again, it's exciting. How do you see your role changing in this new era? If you think back 10 years ago versus 5 to 10 years from now, how do you see your role changing, helping people manage their weight?
My role changes as a kinesiologist or exercise physiologist. Probably new or professional need interprofessional skills, because they have to collaborate with all professionals. That is really important. So, and also what I see is changing is the ability to update our knowledge. At this time, there is a lot of change. There is a lot of medication that are new, and we need now to know how to update our knowledge. And I think it's very important to this skill. So maybe it was done before, but now I feel that there is so much change. The definition of obesity, new medication, so we need to be aware about what all the change was. Yes, and artificial intelligence too. So a lot of change now, and we need to to update our knowledge and our practice based on what is new. So I think that is a change, and before it was the same, but now it is going quickly at this time.
I see the challenge is how to get the people love the movement as part every day. In the nowadays is a very sedentary lifestyle. It's difficult the people considering the movement as part of the day.
And I guess I'll wrap up. I agree that we need to be more multidisciplinary. We have to understand these rapid changes. I mean, things are changing exponentially compared to when you're old like me. You've just seen lots of things happen, and it's like, oh, this is really different than it's been at any point in time in my career. And I think we have to stay updated. I think as dietitian, nutritionists, that we need to go back to our roots with healthy eating and not get caught up in only the weight management, which hopefully I communicated that in my presentation, looking at ways that we can help people sustain lifestyles. From a behavioral health perspective, when people have, it's similar to metabolic and bariatric surgery. Now we're going to have that plus medications or medications that might rival metabolic and bariatric surgery. Anytime you see major changes and shifts in people's lifestyles, they can have major psychological changes, and we have to help them adapt. So partnering with people, no matter what our field is, partnering with them, listening to them, understanding, going to conferences, talking to other practitioners, challenging our own set of beliefs. I think all of those things can be really important. So I just wanted to thank all of you for being here today. I think we've had a nice discussion. Thank you for all the questions. And if you have any other questions or need to contact any of us, please come up when we're done. Thank you guys so much.